And welcome to the Dr. Bob Show. I can always remember playing out in the sun, playing tennis, basketball, being out on the lake, having lots of sun exposure, not really realizing the damage if we don't protect our skin. And now later on, we begin to notice little lesions that begin to appear on our skin. They can be on the head, cheek, face, hands, almost anywhere. We'll be talking about skin lesions, skin cancers that can be caused by sun. My guest is Dr. Meredith Overholt. Dr. Meredith Overholt is a board-certified dermatologist, and she deals with these skin lesions every single day. And she'll be teaching us about diagnosis and treatment. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about aspirin, good medicine, but it does have its problems. Some are dangerous, some are very, very dangerous. And we'll be talking about a condition where the stomach just doesn't seem to work well. It goes to sleep and it's hard to wake up. It's called gastroparesis. Lots of things can cause it, and it does cause medical problems. We'll be answering your questions on those. You'll want to stay tuned. We're talking with Dr. Meredith Overholt, board-certified dermatologist. We're talking about skin problems, skin cancers. Meredith, welcome to the Dr. Bob Show.
Thank you.
Tell me about skin cancers. Are they common?
They're extremely common. The statistics even wow me. It's 5.4 million non-melanoma skin cancers a year.
5.4 non-melanoma skin cancers.
Right.
What are some of those skin cancers? What are some of the common names for them?
Okay, the most common by far and away is basal cell carcinoma. If you actually add up all other cancers in the United States every year, every one you can think, every cancer, you don't get the number of basal cell carcinomas.
So basal cell wins the lead.
It's the number one for sure.
Is it easy to diagnose it, or is it easy to treat, or is it getting more difficult, or it depends?
Well, it does, and there are many different types of basal cell carcinomas, and so we've kind of gotten away from showing pictures in the exam room and everything because they're so common that the chances that yours is going to look exactly like one of the pictures is a little misleading. So there are certainly things that can make you think basal cell carcinoma.
So what makes you think of one?
Generally sun-exposed area, okay. However, 2 hours ago I took off one on a lady's scalp about here, and she had nice thick hair, so you absolutely can have them in non-sun exposed locations. Generally not real fast growing, okay. There's the nodular type or solid type of basal cell carcinoma, and many people describe them as looking pearly or glossy, okay. I think of it as like when you blow up a balloon, you know, when it's not blown up, it's wrinkly and dull, but when you blow it up, it gets that luster.
Shiny.
Yeah, so think of that as the tumor cells pushing up on the epidermis and kind of tenting it out.
How fast do they grow, basal cells?
You know, it depends. You know, you can have, you know, more and less aggressive types, and you can have people with different immune systems. So if you've got a person with really good immune status, you know, they can keep that basal cell growing very slowly for a long time, whereas certainly if their immune system is more poor, then, you know, they can grow more rapidly. So that's the biggest problem with basal cell carcinoma. They don't metastasize nearly as much, you know, it was certainly not like melanoma and even not like squamous cell carcinoma, which can. It's fairly uncommon for basal cell carcinoma to metastasize.
So if you get a basal cell carcinoma on the face, a sun-exposed area, and you sort of scratch the little lesion, what happens to it?
Yeah, it'll scab over and it kind of won't want to heal. That's one of the classic descriptions of basal cell 2.
When it doesn't want to heal, does it want to get bigger?
Yes, it can, and that's part of the problem, you know, is they'll outgrow their blood supply and they'll necrose or die in the center and sort of die back and then begin to grow again. So they'll be there for a while oftentimes before people really get the hint that something's going on. They're pretty easy to ignore, so people sometimes will come in with them being quite large in size, which again, chances of that causing death is very low, but the smaller they are, the easier, cheaper, less painful they are to treat, and the less of a scar.
While we're talking about the smaller they are, the easier and better it is on the patient and the cost. How often should a person have a skin check? I'm fair-skinned, bald-headed. How often should I have a skin check?
Well, there's not a standard one-size-fits-all recommendation for that. You know, generally we'd love to have everybody have their skin checked at least annually, but frankly, there are not enough dermatologists to do that. So, but your primary care doctor can be a good resource. So many of them feel comfortable doing a skin exam as part of your physical annually, and then sending a patient on over to see one of us if there's a questionable lesion. So that's perfectly fine. But certainly for a person who's in a higher risk group, it's better to go ahead and have a dermatologist at least do an exam, assess their individual risk factors, and come up with a plan for how often that person ought to be checked.
Let's go back to basal cell.
Okay.
If you've got a basal cell on the face anywhere, size of a dime,
okay,
what's the treatment?
Yeah. Well, the standard treatment has been surgery for a really long time, okay? And generally that's still considered the gold standard. If it's a solid type basal cell, which is the more common type, or superficial type, those are easily treated with just regular old excisional surgery.
Shave them off, or you have to go a little deeper and close the wound?
Well, if we're talking about face, cosmesis is more important.
Yeah.
Okay, so there are some tricks like you're talking about, something called a curettage and electrodesiccation, where we scrape it off and cauterize it basically, and that's a great treatment, really quick and easy and low risk of infection and bleeding, low cost. Not a bad scar, but maybe not a scar you'd want on your face. Okay, so on the facial skin, we're more likely to do excisional surgery. And again, if it's a basal cell that's in a location that doesn't require major reconstruction, like maybe the tip of the nose, and it's a type that doesn't have, as my patients say, roots, then we can just do that with simple excisional surgery. That's still the standard of care. But there are certainly cases where patients have that same little dime-sized basal cell you're talking about, but in a location that makes it much more difficult. So again, we talked about the tip of the nose, or near a lip, or near an eyelid, and those are locations where you don't have a lot of extra skin to close the surgical defect, and it might be important for a patient to have Mohs surgery.
What's Mohs surgery?
Yeah, it's named after Frederick Mohs, who was a turn of the 20th century physician at Mayo Clinic, who described how you could take out a skin cancer. His term was micrographically, where you take it out and you can then immediately freeze it and check the margins and tell where you need to go back. And then that way you can conserve all the healthy tissue that you can. You're not taking out large margins without needing to. You can conserve tissue, but you have a very, very high rate of getting that completely clear. In fact, it's considered to be 99%. That being the case, today I actually excised a patient who recurred after a Mohs procedure. So nothing is 100%.
Yes.
And when basal cell is so common, you're going to get exceptions to practically every one of our rules. Yeah. The interesting new things in basal cell carcinoma is, we've never had a chemotherapy drug for basal cell carcinoma. Haven't needed one a lot, okay, but there are certainly people who sadly will let these get very, very large, and it's stunning to hear this, but there are people who let them completely remove an ear, or completely remove a nose, or take off a huge portion of a face. And there are cases of metastatic basal cell carcinoma, so this drug, Aroveg, can be used to either treat the basal cell carcinoma completely, or more commonly to shrink it down to size where it can be treated either with surgery or with possible radiation.
How does the medication work? If you've got a basal cell, how did you pronounce it? Ulrich?
Araveg.
Araveg.
Yes. Well, we always laugh at the pathogenesis of this one because there's an immune pathway called the hedgehog pathway. I didn't name it.
Hedgehog, would be easy to remember.
Exactly, and so it inhibits a protein in that, and that's what causes the death of the basal cells. So,
when you
fancy
when
immunology.
you use chemotherapy, when you use medication, you have to go after that? Do you have to go then and excise what sort of remains?
It certainly can be the case. It certainly can be the case.
Results pretty good treating basal cell cancers.
Generally, yes, can be very, very good. And I think we'll talk in the next few minutes about one of the newer treatments additionally. But if you want to talk about squamous cell carcinoma, we can talk about that. That's the second most common skin cancer. And while, you know, it's substantially less common than basal cell, it is actually much more likely to metastasize.
To
okay.
spread.
Yeah, that being the case.
So we're going to take a break.
Okay.
We're going to come back to squamous cell, and
Okay.
then we'll go to some of the newer treatment that
Great.
can involve both,
Okay.
which I think would be very important to the viewing audience. So we're going to be talking about squamous cell cancers of the skin. Is it different from the basal cell? Is it more bothersome, worrisome, dangerous? You'll want to know. Excellent instructions. We're talking with Dr. Meredith Overholt, board-certified dermatologist, skin specialist. We're talking about lesions in the skin. We're talking about skin cancers. We're talking about non-melanoma. No melanoma. We're talking about others, and we've talked about basal cell carcinoma of the skin and what the treatment is, what it looks like, and what we can do about it. Now let's talk about squamous cell. How does it differ from basal cell?
Well, they're very similar. They're actually the same cell, the keratinocyte, or the majority cell in the epidermis, okay? Squamous cell carcinomas are less common, about 10 to 15% of skin cancers, but still that makes up a huge number when you're talking about a base number of 5.5 million, right? So we certainly see them all day, every day, okay? They're more tender, pink, scaly, inflamed, bothersome to people.
How tender?
Can be quite tender, and that's kind of on the fortunate side because people do tend to come in for them earlier. Yeah, they
I've got this thing and
bother
it hurts.
people. Exactly. And that seems to be because they elicit more of an immune response. Okay, but of course, you know, some of our biggest hitters in our clinic from skin cancer standpoint are those with a poor immune system, whether they have HIV, CLL, chronic lymphocytic leukemia, or they're on a drug that might suppress their immune system that they take for Crohn's disease or arthritis or one of those sorts of things. Those are very, very, very common in that population. Transplant patients, wow, they get squamous cell carcinoma a lot.
In immunology, we call it tumor surveillance, where the immune system looks for and attacks and gets rid of some.
Right.
But if your immune system is not working, it gives you a greater chance.
Yeah, absolutely.
Is there a scaliness? Is there a roughness to a squamous cell?
And these have a progenitor lesion, meaning that they often come from an actinic keratosis, a precancer. Basal cells seem to come up de novo usually. Some people debate that, but a lot of people think that, you know, squamous cell carcinomas occur in the beginning as an actinic keratosis, which is one of the most common things that we treat, you know, to try to go ahead and get those nipped in the bud and avoid the cancer later. But yeah, the squamous cell carcinoma is very common, and for the most part does not spread internally, okay, at low rate of metastasis, certainly compared to melanoma, which is why, even though it's only 1 to 2% of skin cancers, that's the one that people know the name of. But squamous cells certainly can, and we've learned a lot over the last few years about how to predict which ones might. Okay,
what do you
so
do?
that's important to know.
We've got skin lesions. They're tender. They can be on any location.
Yeah, so you want to watch out particularly well for lesions on the lip.
Wow.
Okay, and that's why we probably don't do a good enough job talking about sunscreening lips, using sunscreen-containing lip balm and that sort of thing, because lips are a really worrisome place. So lip, ear, and then this part of the lateral cheek temporal area seem to be higher risk locations. Certainly larger squamous cells, so when they're bigger than a couple of centimeters, which is about a quarter or so, about the size of a quarter or so. And under the microscope, when a pathologist looks, if he sees that the cells look particularly aggressive, those are worrisome signs.
So if you get a worrisome squamous cell, something that makes you think it will be more aggressive, how do you attack it? How do you treat it? What do you do?
Yeah, that's where we usually involve some help. If it's in one of those locations, then I will often use an ENT head and neck surgeon or a surgical oncologist to be able to examine the lymph nodes in the area very well using MRI and other techniques to see if there might be any metastatic disease in that area. And in the past, that would just be, okay, we excise it, we radiate the area, and that's still important, and I think those things are still standard of care. Fortunately now there also is a fancy new drug for metastatic squamous cell carcinoma, so we're so fortunate to have so many brand new cancer drugs recently.
What's its name? Does it go with the hedgehog?
No. This one's called Libtayo or cemiplimab, okay? And it's one of the PD-1 inhibitors, so programmed cell death inhibitors. So it basically, you hate to make a cancer almost personified, but there are ways that cancer cells can kind of sneak around the immune system, even if your immune system's in pretty good shape. Okay, and this unmasks the tumor in lay terms, okay, so that the immune system is more effective in attacking it, and they can work amazingly well. They tend to trigger kind of autoimmune type side effects though that can be problematic. So we're glad to have them, but we certainly would rather not have to get to that point.
Sure.
Yes.
I want to jump to some of the newer treatment radiation.
Yes.
SRT. What does SRT mean?
Well, we're really excited to be the practice in Knoxville that has this, and we predict there'll be more, but we got it first. So, so SRT is made by a company called Census, and this has been around for a while. In fact, historically speaking, for those of you who have not heard of radiation treatment for being used for skin cancer, actually the first cancers ever treated with radiation were skin cancers, which makes perfect sense when you think that back when radiation was developed, we didn't have MRIs. Yeah. You couldn't do an internal tumor because you couldn't tell if you got rid of it or not. You could watch a skin cancer dissolve, right? So that was used for quite a while until surgical technique got so good and you could get good margin control. You could tell if it was all out, and that seemed to kind of blow by the radiation techniques.
So how do you do the radiation?
Well, the more new technique is to use a very nice piece of equipment that's got a lot of fail-safes, very, very safe piece of equipment for SRT, which is superficial radiation treatment. So it goes about 4 millimeters into the skin.
So 4 millimeters is a little less than a razor.
Yes, it's not very deep, but it's deep enough to get most basal cells and squamous cells, okay? And, it's less radiation than a dental x-ray per treatment, okay? So we're not talking about, big time radiation. So if somebody's had radiation for, prostate cancer or breast cancer, and they think, oh gosh, I don't want to, that was a lot. People don't even notice. It's very easy to do.
How do you guide the radiation? How do you determine how wide an area that you're going to radiate?
Yes, well, it depends upon the type of cancer. So if it's a basal cell carcinoma, typically you've got about a ½ centimeter margin around here. We usually use about 1 centimeter for a squamous cell carcinoma, and they build the little lead shields that protect the rest of the skin and protect the rest of the person from any radiation, which is not going to happen. But the biggest advantage of this is it is pain-free. Okay, so certainly in a day where we're worried about opioid pain relievers, etc., you don't have to worry about your skin cancer requiring a lot of pain medication to remove, or a lot of discomfort, needles, etc.
So it sounds to me like this is new, innovative, exciting, effective. Does it leave scars?
much better. Of course, you'll probably have the biopsy scar, okay? But with that, really, I've seen pictures where there basically is no scar, okay? So, still, I think surgery can be a wonderful thing. So surgery and Mohs surgery are still gold standard treatments, but even the finest surgeon has a hard time removing something from a nasal tip without some form of scar. This can do better, okay? So minimal scarring. Another beautiful thing is no bleeding. And we have so many patients who are on blood thinners these days that can't really get off of those very easily without it being a health risk, yet they also don't want to experience post-surgical bleeding. So there's that advantage, which is a big one. Another advantage is, gosh, we have so many golfers who get skin cancer. And when I take a skin cancer off their wrist and tell them that they're off the course for a month, they're not happy. So you can do SRT for a skin cancer right here and keep your tea time. So
there are lots and lots of benefits.
Lots of advantages. So some better scarring, don't have to worry about the infection risk. Lower too, we didn't mention that, okay? And these days surgically, I feel like I'm sending my patients out into staff world out there because the infection rate, none of us want to admit it, but has climbed, and it's just because of so many bad bacteria out there and how common they are. And so certainly there are a lot of people who don't want to have to take an antibiotic. Well, if you don't get an infection, you don't have to take an antibiotic.
We've got 30 seconds. How do we prevent all this from occurring?
Try to get your outdoor activities that are important to you done early or late. Wear sunscreen and wear sunscreen effectively. You should look the same color when you come home that you did when you left. If you don't, then you need to either put it on more thickly, more frequently, or up the SPF. Okay, and then plan on using hats and clothing. The UPF fabric clothing has been a game changer. Very helpful. Doesn't rub off, doesn't sweat off, doesn't need to be reapplied. Easy.
I think that's absolutely great. And I have to confess my sins in childhood of getting out in the sun too much.
Yes.
And I think if we could get that warning and that message out to everybody, how important it will be to prevent skin cancers. Meredith Overholt, thank you so much for coming to the Dr. Bob Show. You're a great, great teacher.
Thank you.
Great information. Stay out of the sun or use sunscreen and wear the proper clothing. Protect your skin. Otherwise, it may come back to bite you. And now you'll want to stay tuned. We're going to be talking a little bit about the dangers of aspirin, more than just irritating the tummy, and gastroparesis, whatever that means. We'll talk about those. I want to thank Dr. Meredith Overholt. Wonderful discussion on skin cancers, non-melanoma type. Take care of your skin or it will come back to bite you later on. Now, questions from you, the viewer, that I think will be important to your health. Dr. Bob, how dangerous is aspirin? It's a good question. Aspirin's a great medication. It's effective and it's cheap. So you can't find anything much better than that. But aspirin does irritate the stomach, can cause gastritis, it can cause inflammation, and can cause GI bleeding. There's one other circumstance where aspirin can be life-threatening, and that's an allergic reaction to it. There are some people with nasal polyps and asthma and have aspirin sensitivity. So just a little asthma will cause swelling of the lips or breaking out in hives or coughing and wheezing and shortness of breath. It can be severe, it can be life-threatening. So if you're having a problem with aspirin or ibuprofen type medications, we call them NSAIDs, be sure and talk to your doctor about those. There are things that we can do about that. Question number 2, Dr. Bob. My doctor says I have gastroparesis. What is that? That's a good question. The stomach is what receives food and then it begins to mix up the food. Acid is produced and we get a churning like a cement mixer, and it churns the food and gets it ready to go out into the small intestine. If the stomach doesn't work, if it doesn't churn the food, if it doesn't get it ready, then we call that gastroparesis. The vagus nerve is what activates the stomach. So sometimes the vagus nerve endings in the stomach doesn't seem to work, or medications can do that. Antidepressants can do that. Some ulcer medicines can do that. So there are medications that can cause the stomach not to work, to get gastroparesis. The symptoms are what you think they would be. If you eat food, it stays in the stomach, then you feel full, you get a little nauseated, a little bit bloated, and then you realize that you're just not digesting food properly. When those symptoms occur, talk to your doctor. There are things we can do about gastroparesis. And now, those 4 things that we like in the Dr. Bob Show. Be sure that exercise is part of your lifestyle. Exercise will decrease stress. It will help us lose weight. It will regulate our blood pressure. It will make us feel better, a runner's high. So be exercising 5, 6, 7 days a week. Start the day off with a good breakfast, a breakfast of fruit and fiber. So eat your oatmeal, have fruits, have antioxidants, and remember, the breakfast will get you where you don't get so hungry the rest of the day. As the day goes on, eat less rather than more. Watch the volume of food that you eat. Get 7.5 hours of sleep. Wouldn't that feel wonderful? It would be, because you'll feel fresh, you'll feel better, you'll be more productive, you'll be happier, the people around you will be happier. There are things that keep us from getting a good night's sleep. Number 1, it could be the bedroom. It's not dark enough. There's too many other noises. There are the little blue lights around the room. There are noises that keep us awake. We may have shoulder pain or leg pain. We may have an irritable bladder. If you've got problems that keep you from sleeping, be sure you get those fixed, because there's nothing like a good night's sleep. And most of all, what is it we like on the Dr. Bob Show? It's that laughter in your life. Remember, if you laugh a lot and giggle a lot, you're going to be healthier, and so will the people around you.